We are live now.
Great. Good evening, doctors. I am Dr. Namra Sheikh, associated with Emcure Pharmaceuticals as medical advisor. I welcome you all to another exciting session of No Thrombosis workshop series in stroke on this digital platform. It gives me immense pleasure to introduce our course director for today's session, who is Dr. Subhash Kaul, sir. Sir is working as senior consulting and stroke specialist at KIMS Foundation, Secunderabad. Having an experience of being a faculty for 27 years at Nizam's Institute of Medical Sciences. He's been a former professor and HOD at the NIMS, has a credit of more than 120 publications in national and international journals, and has been the principal investigator of various national and international stroke trials. He's been the past president of Neuroscientists Association, past president of ISA and IAN. We welcome you, sir. Thank you for being on board today.
Thank you.
Then I would like to introduce our moderator for today's session, who is Dr. Meenakshi Sundaram, sir. Sir is working as a senior consultant neurologist at Apollo Hospital, Madurai. With the credit of more than 20 years of experience in neurology, he has presented papers at various national and international forums and has the credit of receiving the Best Research Paper Award at the 10th Annual Conference of IAN at Lucknow. He's been the principal investigator for various international trials, stroke trials, and has been the editor of the South Asian edition of the book Practical Neurology and contributed to many books on neurology. We welcome you, sir, today.
Namaste, madam.
I would now like to introduce our two eminent speakers. Before I introduce the eminent speakers, I would like to introduce Dr. Pradyuman Oak, sir. Sir is working as the director and head of neurology at Nanavati Super Speciality Hospital, Mumbai. Sir has an experience of more than 22 years and has presented papers at various prestigious national and international forums and is involved in teaching activities for neurologists, neurosurgeons, and neuropathologists. He has the credit of doing research and publications in various national and international journals. I would now like to introduce two eminent speakers who will be delivering talk on different difficult cases encountered in clinical practice. I welcome Dr. Vibhor Upadhyay, sir. He's working as consultant neurologist at Medanta Hospital, Lucknow. He's the member of IAN, MDSI, AAN, and has done certificate course on neurology update. Has the credit of being awarded the North Zone winner in TISA competition and has presented papers at various national and international forums and publications in national journals. We welcome you, sir.
Thank you.
Our next speaker is Dr. Ritesh Nair. Sir is working as senior consultant neurologist at SIMT Hospital, Chennai. He is the member of IAN, ISA, IMA, and CNS. He has presented papers at various national and prestigious forums. He has the credit of publications in national and international journals. We welcome you, sir.
Good evening, everybody. Thank you for inviting us. Thank you.
And without further ado, I would now request Dr. Subhash Kaul, sir, to continue the session.
Yeah, thank you, Namra. So I welcome all the attendees and the chairpersons and the speakers to today's session. As you know, Miller Fisher has said that neurologists learn neurology stroke by stroke, and I would modify that neurologists learn stroke case by case, because each case is different. And all those randomized studies and all give us a sum total of the data on thousands of patients. But individuals do not come to us as sum total of average of thousands of patients. They still come to us as individuals. And individual stroke can be learned only by individual cases. And we have been enjoying this journey. So with that, I welcome today's chairpersons, Meenakshi Sundaram and Pradyuman Oak. And I hand over to you, Meenakshi and Pradyuman, to take it forward, please. Meenakshi.
Sir, namaste, sir.
Yeah,
Without much ado,
namaste.
I think we can go with the cases. We are excited to be part of this program and learn from sir, as well as my colleagues and the eminent speakers. Thank you, sir.
Dr. Vibhor, will you please start with your presentation, case presentation?
Okay, okay. Are my slide visible? Hello?
Yes.
It's visible, sir. Yeah.
Okay, am I audible too? Yeah,
Sir,
good
you're
evening,
audible.
everyone. Yeah,
Yes.
good evening, everyone. Good evening, Call sir. Good evening, Meenakshi Sundaram sir. Good evening, Pradyuman sir. So today I'm going to discuss one of my, it's not interesting, but some points are there which I would like to discuss and want to learn from the seniors present here also, which definitely cause day-to-day dilemma to take decision while dealing stroke case. Because as Call sir has already said that each stroke case teaches something every time. So this is a case of 79-year-old lady, Mrs. VD. She was a known case of diabetes, hypertension, coronary artery disease. She was post CABG in 2015. She presented to us with chief complaints of that she went to sleep all right at 11 p.m. and in the morning after waking up have slurred speech with imbalance in walking, she woke up at around 6 a.m. There was no history of LOC, seizure, headache, double vision, facial numbness, incontinence, and there was no history of any trauma, fall, or head injury or fever. So on examination, her NIH score was 5/42. Her pulse rate was 134 per minute, which was irregular. 2. Her BP was 160/86 mm of Hg. She was afebrile. Her RBS was 154 and saturation was okay. She was M6. Her last well-known time was 11 p.m. when she went to sleep and came to ER at approximately 7 a.m. That is 8 hours into the ictus. And she was a case of wake-up stroke. On examination, she was having dysarthria. Her pupil were okay, reactive, but she was having horizontal nystagmus. Along with that, she was having left UMN facial palsy. Her left side subtle weakness was present. Power was almost 4+/5. And on walking, she was having ataxic gait. And her left plantar was extensor. Immediately, stroke code was announced in emergency. And we did a CT scan for her. The CT scan showed a old hypodensity, which was a chronic type in the right frontal region. But apart from that, there was no such hypodensity seen. So at CT scan was normal. So we went through with CT angio, and CT angio showed that there was right vertebral, right vertebral artery was not visualized clearly, and on the above side, the basilar artery was not being formed properly, and then PCA were seen. So we immediately thought that patient was having ataxia also, so we are dealing with a posterior circulation stroke, and maybe she is having top of basilar artery syndrome. So this is again contrast enhancing image. We can see the left vertebral artery which is being filled nicely, and some basilar artery caudal part is filled, but the cranial part is not visualized. And similarly, the left vertebral artery is also not properly visualized. So immediately, as the last well-known time was 8 hours, because she went to sleep normally at 11 a.m. So we were doubtful that was there any stroke or would there be any diffusion flare mismatch? Should we go for thrombolysis? So immediately in doubt, we went for MRI. And the MRI, as we can clearly show that there was diffusion restriction seen in the midbrain, right side of pons, and little small part of thalamus. And it was corresponding with the ADC. And in the FLAIR images, there was no changes seen at these levels. So after obtaining consent from thrombolysis, the thrombolysis was done for the patient with tenecteplase at 0.25 mg per kg. Total 15 mg bolus dose was given. Door to needle time in this case was 40 minutes. We little got delayed because of getting MRI done, as it was the last well-known time was approximately 8 hours. So just to confirm the stroke, we did the MRI scan. After bolus synaptic as patient was having basilar artery thrombosis, which was clearly visible in CT angio, we shifted the patient to cath lab for thrombectomy too. And basilar artery thrombectomy was also done in this case. So patient was later on, patient was shifted to stroke ICU, and a repeat CT scan after 24 hours showed no evidence of any intracranial bleed. Post thrombolysis and thrombectomy, patient's vitals remained normal. There was no headache or worsening of symptoms. Her NIHS dropped from 5 to 2/42. Sugars were controlled, and we did a echo which showed no valvular disease, and there was no LA clot or LA size was also normal. But patient has atrial fibrillation. Forward rate control was done initially. And then this was NCCT head, which was done after 24 hours. There was no evidence of any integrity. Subtle hypodensity is being seen in the left midbrain, right midbrain region. Later, patient was started on Epic-7 5 mg BD, and NIHS discharge was 2. So the final diagnosis patient had that was she was having acute ischemic posterior circulation stroke with basilar artery thrombosis. Post thrombolysis and thrombectomy, she had cardioembolic stroke, which was not due to non-valvular AF. NIHS at admission was 5, and at discharge, she was discharged with NIHS of 2. So the discussion point in this case was that all wake-up stroke to be considered for intervention, as in this case, the last well-known time was approximately 8 hours when the patient went to sleep at 11 p.m. So even if patient is waking up, we are always in doubt that patient could, as always, we take that as patient went to sleep, that will be the time of ictus. But in all wake-up stroke, we should be on toes, and time of onset can be within the window period. But one thing which I want to emphasize in this case is NIHS in posterior circulation may be falsely low, because in this case, as he was having ataxic gait, we cannot label it in NIHS because there is no gait numbering is done in NIHS. Similarly for nystagmus and some cranial nerve palsies. Similarly, in posterior circulation stroke, especially in basilar artery thrombosis, promising results are seen for thrombectomy for up to 24 hours of onset. So one thing was again in my mind that regarding this case, if although the bridging is recommended therapy, then some trials have shown that only after 6 hours that thrombectomy alone should be done. So first, I'll just want to emphasize on some points like pitfall of NIHS. Like in this case, especially in posterior circulation strokes, there are disproportionately biased toward deficits caused by the lesion in anterior circulation. The markings which are majorly given for the anterior circulation stroke as compared to the posterior circulations, like cranial nerve abnormalities, ataxia, they have received fewer points or even been excluded from the scoring. Some studies have also shown that initial NIHS median for anterior circulation is 3 as compared to the posterior circulation, which is almost 2.5. Similarly, in another studies, they have shown that 16 median scoring is for anterior circulation, and for posterior circulation, it comes down to 10. So like additional criteria should be added in some new score, like for nystagmus, Horner syndrome, cranial nerve specifically 9, 10, and ataxic gait, truncal ataxia. So one separate scoring which has come into but not routinely used is posterior NIHS. And few trials I want to discuss here is this attention trial, which is a trial for endovascular treatment in acute basilar artery occlusion, in which they have enrolled patient within 12 hours of onset of basilar artery occlusion, where they have seen that 0 to 3 of MRS at 90 days is being good with thrombectomy group as compared to control group. Similarly, the MRS of 022 was also better in the thrombectomy group as compared to the control group, although there is some risk of spontaneous ICH, which was seen more in the thrombectomy group. But definitely, even up to 12 hours of basilar artery occlusion, we should definitely go for endovascular treatment. Similarly, this Bosch trial, this was also included up to 24 hours of basilar artery occlusion patients, where thrombectomy was done in comparison to best medical treatment. And this has also shown good functional outcome of MRS3 at 90 days in majority of 46 patients as compared to 24 in best medical management group. But definitely spontaneous ICH is little bit increased in the thrombectomy group. And this is a recent trial which is published in this year only in neurology, which has shown that even this is a retrospective cohort single center observational study, in which they have compared the IVT only in basilar artery occlusion as compared to IVT with EVT. So they have seen that even alone doing intravascular thrombolysis in cases of basilar artery occlusion up to 6 hours have shown favorable outcome as compared to the procedure bridging therapy. So specifically in younger age, milder symptom severity and less baseline ischemic changes predicted favorable functional outcome in the cases in few selected cases. So in like resourceful countries like of us, where cost is a major factor, if the patient goes for both procedures, especially thrombectomy, which cost in lakhs. So if thrombolysis can be provided and can give a good hope for the patients, then it would become a cost-effective therapy also in some selected cases. So with this, I thank you. Sir, any comments from your side?
We'll wait for sir
Can
to
you,
comment. That's
can
why
you,
waiting,
can
sir.
you, yeah, sorry. We always forget to mute and unmute. Sometimes we are supposed to mute, sometimes unmute, and we usually end up doing the opposite. But anyway, you see, no, I would do exactly the same way, Vibhor, the way you have done with it. I'll tell you why.
Yes, sir.
For any wake-up stroke, as per the American Association guidelines, you go by the diffusion flare mismatch.
Yes,
So
sir.
you take flare as a surrogate marker of the time.
Okay.
Although now we have learned it is not perfect. There are sometimes flare can occur as early as 2 hours, and sometimes flare can occur as late as 7 hours. We have learned that. But still, as of today, it's taken as a surrogate marker of 4.5 hours, which means if flare has not come, you are within 4.5 hours. So I think your patient did not have any flare changes.
No, sir. No,
So therefore, you are absolutely within your rights to give it. Now, this has been further refined by European organization. You know, European Stroke Association have got their grade system of recommendation, in which it's a very democratic way, in which 5 people say something, 1 person will something. That is like the real world. And in that, whenever they talk of wake-up strokes, they say the flare and all this okay, provided the stroke has occurred within 9 hours of the midpoint of the sleep. It's a very funny concept. You just imagine. So suppose if your patient has slept at 11 o'clock and if he has woken up at 7 o'clock in the morning, so how many hours are happening? You have to see it should not be more than 18 hours. You understand the point? It should not be more than 18 hours. This stroke should happen less than 9 hours. In that case. But anyway, I think this in this case, no, half of the sleep period should not be more than 9 hours. That is the way to look at it. You understood? Half of your total sleep period. So if he has slept at 11 and he is waking up at 7 in the morning, so there are 8 hours, and half of that is only 4 hours. So even from European point of view, also we are comfortable. So I think giving IV thrombolysis is not a challenge. Now, should you go for mechanical in this patient? I would go for mechanical because there was a block. There was a clear-cut block, and you are not sure whether that block will be recanalized. If you would have shown complete recanalization, then I would not go, obviously. But there was a block, and all the blocks don't get recanalized. And this was a good patient for mechanical because at least half of his brainstem was still intact, right? If suppose whole of pons would have gone, whole of midbrain would have gone, then I would have thought it is futile exercise. But at least 50 to 60% of his brainstem was okay. You need only 1/2 of the brain of midbrain to keep you conscious and alert, even if 1/2 is going. So therefore, the interventionalists have their own criteria of predicting which intervention will be successful. In that, one is the NIHS score, which you said posterior circulation NIHS score. Second is the location of the block. The distal more it is, the better it is, which means that if it's at the basal artery, it is better compared to if it is lower down. So I think this patient was a good candidate. I would have done that also. And regarding your third, I think I already answered that. That in developing countries we will do only IV TPA rather than mechanical. I agree with that, but that in some patients that's possible, but not in all patients. When we know that when you know that the artery has not recanalized, it is just like that, then obviously you will do it mechanical if it's possible. So Meenakshi, over to you for your expert comments.
So thank you, sir. Doctor, it's a beautiful case really, because there were several learning points which I got from this case. Now, if you look at that, we have to think out of the box, as sir always teaches us. Think out of the box. I'll tell you what are the things you have done in this case which has really, caught my attention. First is that, see, it's a posterior circulation stroke.
Yes,
Your NIHS was fine.
yes, sir.
When you look at all the dawn and diffuse criteria, if you look at that, the minimum basic NIHS was for the dawn, it was more than 10. For the
Yes, sir.
diffuse, it was more than 6. So it did
Yeah.
not qualify within quotes the accepted present modern criteria for thrombectomy. But
Yeah.
who would like to go for that? We always go out of the box. If a person has got a basilar occlusion, I'm 100% sure he would have otherwise progressed and ended up in a disaster. So we took the very bold decision of thinking out of the box and going ahead and doing with something. And we always have a backup. Even if you look at the wake-up strokes, the wake-up stroke trial, when we looked at that, there were the anterior circulation stroke, which is the common focus of attention for all of us. But when you look at the posterior circulation strokes in the wake-up trial, no, they did not have any significant benefit statistically. The reason was because there were few numbers only, number one. And number two, most of the patients in the wake-up stroke trial who had posterior circulation stroke were minor strokes. They were not the major strokes. Only when there's a tough exam, people like you can shine. When the exam is very easy, then you cannot pick out who is good and who is bad. So that was the reason probably why they could not really demonstrate the exact benefit in the wake-up stroke trial for the posterior circulation. And thirdly, when we look at that, diffusion flare mismatch, all the concepts, if you look at that, they have all been predominantly evolved for the anterior circulation strokes. We do not evolve that concept in the posterior circulation. So at least for one good reason, because we all know in an anterior circulation, so as sir said, sometimes mismatch can happen late enough as well. Or in another person, the flare may start showing changes even earlier also, making our life miserable. Whereas in posterior circulation stroke, we always know majority of the times the flare changes happen quite late. We know that this is going to give more time for us to intervene. And that was one of the reasons why we were more aggressive in giving, because number one, leave them alone, they end up in disaster. And number two, fortunately, we have a higher window for us to operate. So all these things you demonstrated to us. It was a fantastic case. I learned a lot. Thank you very much.
Thank you,
sir.
thank you, thank you.
Thank you, sir.
Dr. Pradyuman Oak has not probably joined, right?
Sir, I have a question in that case, sir.
Yeah.
The NHSs which you mentioned was the anterior NHSs, right? So
Yes,
did you include the NHSs, the posterior also, cough, dysphagia, and the truncal ataxia, and put them in to give a score? Did the patient have any of these things? Just curious to ask this question.
yes, sir. The patient has those things. Patient was having nystagmus. Patient was having a gait ataxia, imbalance in walking. So today also I want to add that case but I already prepared this one. Today at when I was in duty at 3 a.m., 3 p.m., one patient came just slurring of speech. He was inspector in police and he came within 1 hour into the hospital. And when we checked him, he had an NIH score of 1 only. He had slurring at the onset, but when he reached to emergency, he was just having minor UMN facial palsy. So we immediately did CT followed by CT angio. So CT was clean and CT angio showed again basilar artery, top of basilar artery, near complete occlusion. But NIHS was only, I was able to grade 1 because of UMN facial palsy, but in walking, he was having gait ataxia. And that was significant. He was walking like just broad ataxic gait. And apart from that, everything was normal. Then we did a MRI scan immediately, and we found that just punctate type of lesion diffusion restriction was there in midbrain. Now I was stuck what to do, either to thrombolize or I cannot take with NIHS of 1 to thrombectomy also, although he was having near complete occlusion of top of basilar artery. Then we again gave option of thrombolysis definitely to him. with having in mind that if he gave consent here and he bled, then it would be on us. So definitely he again took the decision of not going for it, and we loaded him with antiplatelets, aspirin, clopidogrel, and atorva. But this was again a challenging case for me. At that time, I was thinking what to do, because anyway, if that near complete oxygen change to complete, then definitely he is going to having a devastating posterior circulation stroke. So at that time, thrombolysis option I gave him, but then again, NIHS score of 1 just for minor UMN facial palsy. Then how I could justify it later on if he bled? So that was one question which I want to have a comment of you and sir for that. What should be done at that time in this case?
You see, this is a Shakespearean question: to be or not to be,
Yes.
right? And I don't think anybody is born in this world so far who can answer that question. And because everybody's concern is same, that if I cause a complication, then I have gone beyond the guidelines. And if the patient worsens, then again I'll be cursing myself why I did not do it. And it's not that the patients don't worsen; patients do worsen. And in fact, for the last, almost to my knowledge, at least for the last 5 to 7 years, this is a debate in all meetings, national and international. LVO with low NIHS, LVO with low, should you intervene or not? And this debate is not ending, everybody. But I had an opportunity of talking to some interventionalists at very close quarters when I went to their center for some. It so happened I went as a inspector, DNB inspector, once for stroke and once for DNB. Vikram Hooded and Gigi from Kerala, they do this all the time. And both of them told me once for all that they don't intervene in low NIHS. They know that it can worsen, but still they don't intervene. They keep the patient under observation. And at the earliest sign of deterioration, they will intervene. Now, that is not a perfect method, but I think they say that we also want to be on the right side of the guidelines, so that, they are thinking of their own safety also. But both of them said, if they are, I mean, you can quote me, because both of them have told me that they don't intervene in low NIHS, but they keep the patient under observation at the earliest progression. But that thing does not work in all cases. That thing will work if the patient has come to you at 4 or 5 hours or 6 hours, so that you have next 18 hours to observe. But if a patient comes to you at 19 hours or 20 hours, now if he worsens after 4 hours, you are out of 24 hours at that time. So, those questions. But as of now, going by those people, I respect them because they have a lot of experience. I would not interfere in these low NIHS patients and hope that they stabilize, knowing fully well that they may worsen. Then at that time, we will do whatever is possible at that time to do. Yeah. Meenakshi, your comments. I'm sure you're a very aggressive person. You would probably go ahead and thrombolize and do mechanical thrombectomy. I know you. Tell me, please, your comments.
Regarding thrombolysis, obviously I will go ahead and thrombolize, sir.
Yeah.
Because I have learned this from my mentor, Professor Dr. Subhash Kaul, sir.
Okay. Yeah.
He has said that we have to thrombolize. Thrombolysis, yes, I would have taken up, sir.
Yeah.
Because even, but as sir said, data is not supporting us. Even the Pooja Khatri's data, the PRISM's data did not support that when you thrombolize in no NIHSS, benefits were seen. It was not supported in that trial.
No, the question is about mechanical thrombectomy if you have a large vessel occlusion and low NIHS.
Mechanical thrombectomy we wouldn't touch, because as you have said, sir, our interventionalists also would not touch, sir.
Yeah.
He would say we won't touch it. If there, as we always keep them under observation, we put them through a chart, and actually the patients go through a torture, because every hour they will be asked to lift their hand and they cannot sleep. 24 hours later, when you see them, there will be one thing they will tell, sir, it is very tiresome after being in the bed. Every hour you ask them to lift their hand and show their teeth, it's tiresome for them. But we do that, sir. 24 hours minimum they are in observation.
Yeah.
We wouldn't touch with mechanical, we wouldn't touch them.
Yeah.
But in this case, probably IV, it is okay, because if there is a vessel occlusion, it might open, because there are good data to show that tenecteplase at least opens several of these major vessel occlusions. So if the patient has been agreeing, obviously the patient has to agree that we are doing outside the guideline. If they are agreeing, I would have thrombolized this patient without hesitation, even though there was only a small infarct, because the large vessel occlusion is sitting there.
No, but
But
at how many hours you got him? This patient
Sir,
which you are telling before.
1 hour,
one and
sir.
half, 1.5 hours, sir.
Oh,
Means one.
okay. So he was
Hmm.
within window. He was within window. Yeah. Okay.
Thrombolysis would have done.
Mm. Yeah, I think that is great. I think we can move to the second case. And thank you so much, Vibhor. Great
Thank you,
case.
sir.
Yeah.
Thank you.
Dr. Ritesh?
Namra Pradyuman Oak has not joined.
Sir, he is involved in some emergency
Okay.
case, so he won't be
Okay.
able to join.
Okay. Fine.
Hello.
Yes, go ahead, please, Ritesh.
Yes, sir. Good evening, sir. So
Good
one
evening.
question to Vaibhav, sir. Whether he converted for thrombectomy the patient to general anesthesia. That is the only question.
I can't hear. What is the question? Please repeat slowly.
So for the first case, when Vaibhav discussed after wake-up stroke,
Yeah.
whether for doing a mechanical thrombectomy, patient was taken for general anesthesia.
Okay. That I
Or
think that also is a maybe he was uncooperative or something like that. Otherwise, there are usually you can
no,
do
sir.
them under.
Yes, so then that becomes question, whether he did it under general anesthesia or not.
Vibhor, you can answer that question.
No, she was being managed with local anesthesia only.
Okay, no, good choice.
Hmm.
Because then we may not understand the deterioration. That's the other problem.
Yeah, that one thing that is also
Yeah.
problematic.
If it's a borderline case, as sir was mentioning, Vikram also follows the same. We should not. The threshold for anesthesia intubation should be high. We should keep it very.
But is this usually done under general anesthesia? These mechanical thrombectomies?
Then
What is the
maybe
usual
that's
procedure?
it's a patient uncooperative or BP very fluctuating.
Okay.
Then general anesthesia is better, sir.
Okay.
Operators prefer that, sir. Because
The-
if the anesthesia team is on ground, it takes additional, maybe 10-15 minutes additional.
But there is one term called conscious sedation. That's not used.
Yeah,
Conscious.
we try to the best level, we try with conscious sedation. But in posterior circulation, like this borderline cases,
Okay.
better to do with conscious sedation only, because deterioration, we may not
Okay.
be able to appreciate.
Okay, boss. So thank you so
Thank you.
much. Yeah.
Thank you, sir.
We can go ahead with the second case, I think. Ritesh.
Dr. Ritesh, will you please share your screen?
Hello? Hello?
Yes, sir, we are checking with Dr.
Okay.
Hitesh.
Okay. No, I just wanted to know that everybody is around or not, because there was silence.
You see, that's a deafening silence, sir.
Yes.
Sir, while we are waiting for the speakers, sir,
Yeah.
sir, tell us, will there be any other molecule other than tenecteplase and alteplase which may come, sir? Is there any future for other molecules, sir?
Now, other day somebody has used retiplase in Hyderabad. No, I have no knowledge about it, but it seems some people are using retiplase. I mean, have you seen anybody using? No, it was given in stroke and he got a massive bleed, and that's how he landed with us. And I thought I asked him, was it given for cardiac? He said, no, sir, it was given for stroke. So no, to the best of my knowledge, I don't think there is any drug which is even near tenecteplase as of now. We have only these to do. Are you aware of any drug?
Sir, no, sir. The retiplase, I'm very upset, very surprised, sir, because they're giving the two split doses. How are they using in stroke, sir?
No, I
In
don't
MI,
know. I have never
they
used
actually
it.
split it and give one now, and after some time they give, I think, half an hour, 1 hour gap they are giving. How
Yeah.
in the world they can use
No.
for
First of all, it's not in guidelines, so I have never focused on this. But he came to me with a brain hemorrhage and having been used. Must be cheap. It must be cheap, I think, right?
No,
I
sir, I
don't know.
don't think it. Everything is in par, sir. I don't think it is cheaper than tenecteplase, sir.
Okay.
Desmoteplase went through all this data, no, sir. Why it did
Yeah.
not stand at all, sir?
No,
DDAS and DIAS and all.
no, those trials did not show any statistically significant advantage. So right now, I don't think we are only waiting tenecteplase from different companies are competing with each other to produce tenecteplase so that price may go down. Because other than BI and this company, Emcure, some other companies are also thinking of launching tenecteplase. But I'm not aware of any drug in the pipeline which is near. There are a lot of thrombolytic which they are doing, but nothing which is something which is available in US or about to be available. No, I'm not aware. See, all those
So
initial
many names we see so many, sir.
Yeah.
Monteplase, Comitiplase, Lanotiplase, Alfimiprase. So many funny names, sir. But
Yeah.
nothing has actually been successful. Really.
Yeah. That's true. And even see, we still have to have a ideal thrombolytic agent. Even this alteplase and tenecteplase also do not guarantee you their success rate is not that much as we would have liked to be. At least there should have been 95% success. But it's not that. So we are still in search of a better, safer, effective thrombolytic agent. I think it will probably come. But as of now, this idrosuzumab also is given half and half, 2.5 and 2.5. I don't know why that is so. Why they do that? What you are telling about retiplase, same thing is in the guidelines of idrosuzumab also. You don't give one shot, you give half and half.
Which one,
Maybe
sir?
some idrasuzumab as an antidote for
Okay. Dabigatran.
dabigatran. It's clearly mentioned there. Give 2.5 and then again give 2.5. May have to do something with pharmacodynamics, I think. That is a field in itself.
Now the newer
Sir,
generation they are targeting is the plasminogen activator inhibitors, sir.
Yeah,
PAI.
yeah,
That is
yeah,
what they are targeting now, the fourth
yeah,
generation. Probably it may have more specificity, I think, sir.
yeah, I think so. Ha, Namra, where are we?
yeah, sir. Actually, Dr. Ritesh is finding some technical difficulty. He's
Okay.
saying he won't be able to present.
Oh my God.
Okay.
Uh,
So, so we are already almost, we have finished the time also. It's 8:51. What do you want?
sir, may we conclude the
Yeah,
session?
yes, sure.
So, thank you so much, sir, for providing time for this meeting, and we are extremely grateful to you for the same.
Thank you. Thank you.
I would also like to thank Dr. Meenakshi Sundaram, sir, for the wonderful insights that he gave us, and Dr. Vibhor Upadhyay, the speaker for today's session, for the wonderful case discussion.
Thank you.
The audience must have definitely benefited from the same, and soon we will meet for another exciting session on of no thrombosis workshop on acute ischemic stroke. Till then, good night.
The other thing, Namra, before we part, because
Yes,
this happened with me yesterday in another webinar also. I was giving a talk and I finished giving the talk, and during question and answer session, my internet connectivity became little disrupted. So this can happen. So one of the things which you can consider in future is that you can ask the speakers. I mean, you don't insist on it, but if they don't mind, I think it's better to keep a backup copy of presentation with you. So they should present. The first choice they should present live. But just in case of difficulty, then you can, from your side, because you will have the advanced copy with you, you can show the PPT and they can present it and they can say next. We used to present like that only, next. So that way you can be, that is a checklist kind of a thing, so that we have the presentation with us. You can consider that in future.
Yes, sir. Definitely. Noted, sir.
Yeah. Okay. Thank you.
Thank you, sir.
Thank you, Meenakshi. Thank you, dear.
Thank you, sir.
Thanks all, friends. Bye.
Thank you, Dr. Vibhor. Thank you, sir.
Thank you, sir. It was
Thank you,
nice
sir. Great.
happening.
Thanks.